effective for endometrioma, as far as I know. Thank you.
Okay. The first is for the progression. It is important to understand if it's a progression, because it is also reflects what you are in surgery. Because if you go and do not a radical surgery and you leave something and there is not a progression, you can much more better do not a radical surgery. So much more conservative, because you know that you deal on the symptoms, but the disease does not progress. But I am not sure, and I don't know the progression of the deep endometriosis. Really, in my life, I see the progression of adenomyosis, because I have a lot of follow-ups. I see the progression of endometriomas, because if you see it 2 centimeters and then it's 5. But I don't never see that a small rectal node become a node of 5 centimeters. And so I don't know when it happens. And this is for you also a question, why? And if I'm sure that it's not progress after this, I can remove only a part, and then for the endometrioma, I'm sorry, but we have a lot of data that endometrioma disappear with the medical treatment. And this helps a lot, especially when you have a problem of infertility. I understand that endometriomas makes oocyte quality not good. So we have to a little bit to joke with medical treatment and surgery, but it is important that you do medical treatment by endometrioma.
But yeah, this is something strange that you say you have never seen a small nodule become big, because if you find 5 centimeter nodule, it should have been at some point 1 centimeter.
Yeah, well,
so I mean, this is the...
But
I would like to hear the theory of Philippe, because Philippe pretends that is a non-progressive disease.
It's progressive over a few years, which means when it starts, you grow a deep endometriosis, but this is done in a short time.
Okay.
And at a certain moment, it stops by itself. It means most, in older women, when you see a small nodule, it's not going to get big. But it has to have been small at a certain moment.
No, but still, you have indirect data. Huh? If you look in complete surgery, the two main factors of the risk of recurrence is first age and two, completeness of surgery. So it does mean that this is progressive, indirectly, no?
I don't know, but finally...
No, but I agree. This is like most of them like fibroid. So I mean that they grow and then they stop. Yeah, but
the most important prediction of recurrence is the surgeon.
No, it's the age of the patient.
But for sure, sometimes you see this huge node, and then the surgeon said, we have to remove it because they will grow, there is occlusion, they make it very big, very worsen. Whereas it remains like this for years. And so
that's why if you have a nodule without clinical sign, don't touch. Yeah. Any question? 1, 2, 1. Microphone.
Should I go first? I would like to ask, what is your suggested approach for very young patients, 14, maybe 16, who complain for nearly debilitating dysmenorrhea? You do not have the option of endovaginal ultrasound, maybe not even gel intravaginal for MRI or intrarectal. What should we do in these situations? Thank you.
So when I have severe dysmenorrhea, that means that they are adolescents that don't go to school. Sometimes they go to emergency, so severe. I go transrectally. And this is the same. And
with the endovaginal probe?
With the endovaginal probe? Yeah. And I think that it's important to have the good diagnosis. And sometimes you have most uterosacral ligaments and adenomyosis. So this uterine contraction are probably for me, one of the cause of abnormal uterine contraction, one of the cause of the endometriosis.
Thank you. Maybe this is...
I know that you are not agree with me, Professor Koenigs, but the uterus is one of the most important features.
Yeah, and I think that I think we have to look at this adenomyosis of young patient because it's not the same. It's not the same compared to older patients.
No, for sure. Yes.
We had a question there.
So I had one comment and then one question for the experts. So as part of the younger generation that now uses mostly ultrasound in our office, I think one of the nice things about ultrasound, especially for patients who we don't see DIE but have, for instance, a lot of tenderness on exam, that really helps us identify superficial endometriosis because we have not yet developed our technique to identify these superficial lesions. But for the experts, sometimes what I struggle with is when to do a peritonectomy, when we have diffuse superficial endometriosis. So my question is, in your expert opinion for economical dissection, should we be doing peritonectomy in patients with diffuse endometriosis or even a negative laparoscopy for microscopic disease?
So I have to admit that I send very, very less patients to surgery. And for me, the surgery means not responded to medical treatment or infertility, not responded with a recurrent implantation failure. Because we try to make it a little bit more, less aggressive in the time. And finally, we have a lot of patients, and the indication to surgery has to be very accurate because it is not easy, or it is after surgery, there are complications. And for bowel resection, there are no pain, but they don't empty their bowels, and they have not empty their bladder. And we have two, especially one clinic in Rome, in Italy, because in Rome not so good, in Italy, and they are very aggressive. They make also all the nerves dissection, and then the patients come back. They don't come back to the surgeons. They come back to us, which we are dealing management of the patients. So endometriosis, to manage an endometriotic patient is a management one-to-one. It's really good. You have to deal with all, psychological, diet, physiotherapy, and the surgeons is one. Important, but not every time the best.
Yeah, but to come back to your question, your question was what?
Peritoneum.
Yeah, but should we do
Only if it's-
peritonectomy in patient without
With the
evident sign?
So in my practice, I don't typically do a peritonectomy. There are practices that do a peritonectomy with a negative laparoscopy for microscopic disease. But there's also people who have diffuse lesions all over, posterior cul-de-sac, anterior cul-de-sac. And oftentimes a significant amount of peritoneum is dissected off, but we don't always know the complications of that after.
In my experience, that has been driven by IVF people. Not mainly for pain, but for infertility, telling that, and I have received a lot of patients sent for resection of the anterior and posterior cul-de-sac because of BCL6 positive and infertility. And I do not advise to do that because, as you said, Douglasectomy, to call it classically, is associated with a lot of complications, which are either neurologic or adhesion. And so...
But my question is that if you give 3 months or 6 months GnRH antagonists, which is a pill, okay, and you continue to see these lesions on the peritoneum. This is because these lesions, the superficial lesions, as some adenomyosis lesions, completely disappear.
This is a very vast question. Philip, and then we...
Peritonectomy is something of the late 80s, early 90s, because in women with pain or infertility, but the others we don't know because we do not do a laparoscopy. So in women with pain or infertility, if you take a piece of peritoneum, normal piece, you have between 10 and 20% endometriosis lesions. This was the area, the period of the microscopical endometriosis, and that's why they did peritonectomy. But then they left it, but it's still around. I don't think, like you said, there's a reason to do it.
Okay. Perfect. Mr. Rabichong, just bounce on what Katerina said about the people that remove too many things.
Yeah, I will try to give you important take-home message about that and neurological consequences of certain surgery. Nerve sparing is a very famous word in our surgery, in our daily surgery, in radical surgery. Today, when we speak about nerve sparing surgery, is mainly in the field of cancer, even if since the Lake trial we discuss less this point in cancer, and we have more and more publication in the field of deep endometriosis surgery, even if, of course, we don't have any RCT comparing nerve sparing without nerve sparing. We have just some retrospective study. We've seen before in the first presentation, and you understand why you need to have today a perfect knowledge. It's really unacceptable to don't have a perfect knowledge of pelvic neuroanatomy when you want to do this kind of surgery. That's clear. 15 years ago, we said you need to have a minimal theoretical knowledge. Today, we said it's unacceptable to don't have it. We have always the same question: is it feasible? Is there a standardized technique? And is it effective and safe for the patient? Of course, this is the most important thing. We can do the difference for the beginning between two kinds of indication. The first is the cancer, the cervical cancer, and the radical yeast. And it is absolutely not the same thing as endometriosis because we have a normal retroperitoneal anatomy. You don't have an extension of the disease outside of the cervix or of the uterus. And in other words, we can follow certain surgical landmarks. This is a perfect example of the deep uterine vein. But on the contrary, with deep endometriosis surgery, we have a distortion and a contraction of the retroperitoneal anatomy. We have a lot of change in the anatomical relationship. And most importantly, we have a possible extension of the disease around the nerves in the retroperitoneal anatomy. So the technique is not the same and the strategy is not the same, more importantly. So what about the surgical strategy and the different requirements we have to follow? I think we can resume this point in three questions. The first is what we have to know before the surgery. Of course, we have to know the pelvic neuroanatomy, of course, what we have to do before surgery, and what we don't have to do during surgery. The first, and beyond the surgical anatomy we've seen previously, we have to know also about the internal architecture of the nerves to understand how it's super easy to create some nerve injury when we do a classical surgical dissection. And you see, we speak about fascicular internal architecture. So it's not like a ureter or vessels. Inside a nerve, through the epineurial sheath, the external sheath of the nerves, we have a very, very sophisticated word with some fascicles. And inside, fascicle is a functional unit of the nerves. And inside each fascicles, we have the axonal fibers and the real nerve fibers, in other words. We see perfectly today, of course, this internal architecture when we are in front of big nerves. You see here on the left, the right femoral nerves. Here we have, with the robot, on the right side, the lumbosacral trunk. And we see that when we open the epineurial sheath of the nerves, we have different fascicles, with inside all the fascicles, some axonal fibers. But it's not so simple than the draw of this anatomist with 4 or 5 fascicles inside all of nerves, because if we take just in human, the hypogastric nerve, remember that it's a nerve of 2-3 millimeters of diameter, not more. For this nerve, at the level of a promontory, it's possible with immunohistochemical methods to identify around 15 middle-sized fascicles. Middle size, it's between 0.05 to 0.02 millimeters, with inside all of them around 500 nerve fibers. And besides that, we have also more than 50 fascicles with a diameter less than 0.05 millimeters. So you can imagine in a nerve of 3 millimeters in total of diameter. It's really, really amazing. And other thing is, it's very easy to create a nerve injury. Look, it is in the rabbit with a sciatic nerve. Sciatic nerve in the rabbit is a big nerve, but you see that with the force applied on the nerves just over 0.3 Newton, we have a complete conduction blockage of the nerves. So you can imagine when you deal with the pelvic splanchnic nerves, when we deal with an hypogastric nerves, it's super easy to create an injury. And in this, it is not related to the nerves, but it is a strength developed by a novices group and an expert group of surgeons when we ask to them to apply a moderate traction on the peritoneum with a grasping forceps. Even expert surgeons develop a mean force of 3 Newton. So you have 0.3 and you have 3. So you see, it's really, really super easy. And in our daily radical surgery of deep endometriosis surgery or cancer or even urogynecology, fortunately, the injury we can create on the nerve is, you see the classical description by a neurosurgeon with 5 types of nerve injury. In most of cases, in gynecology, we are in the grade 1 or grade 2. So neurocmesis or apraxia of the nerves. Fortunately, in most of cases, it is a non-definitive injury of the nerves, and after a few weeks, few months, we will observe a recovery of the nerve. This is a classical story about the bladder atonia in deep endometriosis surgery. We have a lot of patients with bladder atonia of 3, 4 weeks, 1 month, 2 months, 3 months. Fortunately, in a lot of cases, we have a spontaneous recovery, but pay attention to that, and you have to keep in mind this knowledge before to do this kind of surgery. Probably the most difficult steps, and I agree with Katarina, this is a diagnostic step, and this is the key point in the strategy for this surgery. It is the most difficult because first you need to have the knowledge, theoretical knowledge, and you need to take your time to question and to examine correctly the patient. Specifically, if you search for a nerve involvement, you have to know which nerves. If it's a somatic nerve, of course, you need to have the knowledge of the different dermatomes. You need to have a precise, very precise description of the pain besides the classical dysmenorrhea and dyspareunia, the type, if it's a visceral pain, if it's a somatic pain, you know the difference, I think, from the theoretical point of view. But today also, you need absolutely to describe precisely the functional disorder regarding the urinary function, digestive function, and today more and more also sexual function. So, of course, it takes a long time to assess everything. And at the end, you can decide for imaging. And of course, in most of cases today, we use the ultrasonography. And in a lot of cases, we complete also by an MRI before the surgery. But you need at the end to be more a neurologist before a pelvic surgeon. And it's not easy, and that's why more and more we see the development of some multidisciplinary team with a surgeon, with a radiologist, with a physiotherapist, etc. Now, what we have to do, of course, we have to try to preserve the nerves and to do a nerve sparing when it's feasible, because we will see that it's not always feasible, and sometimes we have to do some choice between the radicality and the nerve injury, or to preserve the function, and it's also according to the patient and to the symptoms of the patient, and also very importantly to the information given to the patient before the surgery. That's why also the diagnostic approach before the surgery takes a long time. Sometimes it's really easy, you remember this video, to preserve the nerves without injure it. You see here, it is not a very big nodule without lateral extension in the parietal space, so it's easy to identify the hypogastric nerves and to push out of the area of future dissection the nerves. But here it is another example where it's not feasible, because we have a real entrapment of a pelvic splanchnic nerve with a very large rectovaginal nodule going until we are on the right side, going until the pelvic side wall. And you see we have the S3 sacroilioventral root, we have here the inferior gluteal vein, the piriformis muscle, and you see that we have a real entrapment of the pelvic splanchnic nerves by the nodule. So of course, at the beginning, the team tried to make the dissection between the nerve and the nodule, but after a few minutes, you have to take the decision if you want to be, if you will be radical or if you want to preserve the function. In this kind of case, to be honest, we are going to be radical and we are going to cut the nerve for two reasons. The first is a surgical reason, because if you have few years after this first surgery a symptomatic recurrence at this level, it will be a nightmare for a second surgery. Look the vein, look the diameter of this vein, look all the vessel around. So if you have to go again on this area few years after, it will be a nightmare. But more importantly, we can think, and that's why the diagnostic approach is super important also, we can think that the function of these nerves was impaired before your surgery due to the small diameter of the nerves. That's why sometimes we use a urodynamical examination to assess clearly the urinary function. So in other words, at the end, what not to do during surgery? It's clearly today recommended to avoid a systematic full dissection of the nerve when you don't have an indication to do it, when you don't have an involvement or an entrapment of the nerves by the disease. I don't show you the different publications about nerve sparing. One of the most famous comes from Italy and from Marcello Ceccaroni, an expert in deep endometriosis surgery and nerve sparing surgery. And the initial papers was very impressed for people due to the quality of the picture, with a full dissection of all anatomic, autonomic nerves of the pelvis. But when you pay attention to the picture, you can see that at the end there is no disease around the nerves. And when you look at the results of those surgery, you have a mean number of days of self-catheterization of 40 days. 40 days is a lot, even for colorectal surgeon when they do cancer rectal surgery. So that's why this is typically the demonstration where you don't have to do a systematic dissection of the nerves if you don't have an indication. And this is the oldest recommendation of the French National College, and also the conclusion of the meeting organized by Arnaud here in Strasbourg, the consensus meeting in 22. What you have to do now, if you have an indication, if you have an involvement or an entrapment of the nerve by the disease, you have to follow some surgical rules. It's not always very easy. First, you can read the literature of neurosurgery to see how to do correctly neurolysis, different type of neurolysis, external, internal, interfascicular, etc. We tried to simplify a little bit those rules, and we wrote a paper with Atanas Alexandrov 2 years ago, published in Fact View in Vision, about how to dissect and to give some gynecological surgeon simple rules to follow to minimize the traumatized for the nerves. And you see here different tips and tricks. The first, of course, the first thing is to learn to read your picture. It is the story of the hypogastric nerves. Remember that in most of cases, it's possible to identify it without any dissection of the peritoneum. That's clear. Avoid, please, this kind, and this video comes from Clermont-Ferrand, I'm sorry, a long time ago, but it is in sacrocolpopexy to show to people during live surgery the right hypogastric nerve. So we grasp the nerve, we pull the nerve, etc., etc. So we were very satisfied to show to the two people the nerve, but when we do that, clearly, we do a big mistake and we injure the nerve and we create a neuropraxia, clearly. You have to do an atraumatic dissection as much as possible. You see here, don't pull, don't grasp the nerve, do the dissection around the nerve in the paraneurial tissue. I agree with you that when you see this kind of picture, we don't have the correct instrumentation to do this kind of surgery. We need to improve our instrumentation. We need to have a smaller instrument. Here it's 5 millimeters, 3 millimeters, it's a little bit better, but even 3 millimeters, it's a little bit big to do that. And if we have an indication, as here with an entrapment of the right lumbosacral trunk by a nodule of endometriosis, we have to follow the neurosurgical rules of dissection. It's a little bit like a rectal shaving. You have to minimize the application of energy as bipolar forceps, and you need to use more the cold scissors, the mechanical energy, to make the dissection of that. Yes, But of course, in this kind of case, you see, we did an external neurolysis, but also an internal neurolysis with an interfascicular neurolysis. That's why you need to, the diagnostic approach is so important to give the correct information to the patient also before the surgery about the potential consequences of the surgery. Can we do better? We have some specific instrumentation at the CUSA waterjet dissection. I will show you the different things. The Cavitron, the CUSA aspirator is an ultrasonic aspirator using in liver surgery, in neurosurgery. The principle is to use a very fine needle to aspirate just the low density collagen tissue, as you can see here. You see the probe, you see we have a nerve just here, it is in the pig. You see the nerve here, just over there, and you make the dissection around the nerve without trauma on the nerves. We can use also the intraoperative neuromonitoring. During a long time, it was not super easy to set this method in our daily practice, but today we have some device where it's possible to have with one machine the record of the bladder stimulation and the bowel stimulation. In fact, when you think you are very close from the nerves, you are going to use a bipolar probe, a specific bipolar probe during the laparoscopic surgery, and you do a stimulation of the connective tissue, and you see if you have a manometrical response in the bladder. So if it's the case, you are very close from the autonomic bundles for the bladder, and you analyze also, you record also the electromyographic response in the internal anal sphincter. So today we have some device where it's possible to do both during surgery. It's also possible to implement this method on the robot. And it's well used. It's well used by digestive surgeons, specifically in Germany, for the rectal cancer. And we are always waiting since now 4 years the results of RCT comparing in the nerve sparing surgery for rectal cancer the use of the intraoperative neuromonitoring or no. The robot, yes, not sure. Yeah, we have some advantage with the robot. Clearly, for me, the main advantage is the stability of the vision. Not when you deal like that with hypogastric nerves, because we are very superficial in the pelvis, but more when you are in very deep space, when you have to deal, when you do, for example, sciatic pudendal nerves, it's an advantage to have the stability of the vision. Of course, the wrist articulation of the instruments is also an advantage when you have to do this kind of dissection, but the size, again, of the instruments is too big today to be really effective and to be no traumatic with that. You see here, it is an example of interfascicular neurolysis on the lumbosacral trunk, but you see the size of the tip of the scissors is not really adapted to the procedure. We can think, of course, for the future about laparoscopic neuroimaging. We know that we have some startups since a few years who work on specific biomarkers to identify nerves and specifically autonomic nerves. Today, of course, certain teams use also ICG to do it, but really ICG is not very convenient to do that because you need to make the intravenous injection the day before the surgery, and you need to use 5 milligrams per kilo to see autonomic pelvic nerves with ICG. So you see some example here with the superior hypogastric plexus, autonomic nerves in thoracic surgery in the thoracic cavity. But look, I take always this example. It is a first machine MRI with 11.7 Tesla. Just one machine in the world in Paris-Saclay University. And you see, when you see the level of precision to image your brain with this new MRI, and you see this is your daily MRI, 3 Tesla, 7 Tesla today for experimental study, and the future is 11.7. You see the difference between today, tomorrow. So we can think probably, and this is the lesson of Katarina with ultrasound also, we can think with the classical imaging methods, we can really improve the preservation and the identification of the nerves. We can use also beyond ICG the capacity of autofluorescence of nerves. And this is an example in breast surgery. We have also some example for parotid surgery. But the problem today is we need to have a specific camera to eliminate the nerves and to show the autofluorescence of the nerves, and there is no endoscopic camera adapted today to do that, but probably in the future. And to finish, it's not possible to avoid to speak about artificial intelligence. Last year, it was the first paper about that. It was a paper from Japan, where from more than 800 video recording of rectal cancer surgery by laparoscopy or robotic surgery, they establish deep learning models to predict where are the nerves and pelvic autonomic nerves when they do cancer rectal surgery. And you see here, it's not ICG, and it's a specific filter on the robot. And you see, of course, it's very promising because you see without the AI prediction on the left, and you see on the right with the AI prediction. So it is an easy case because even with AI, I can see where are the nerves. But you see, for people who are not trained, not well trained in this anatomy, AI prediction could be a very good assistance. But to moderate a little bit, because there is not a lot of paper about that during the last year, but another one from Japan, very recent, where they do the same thing for the rectal surgery, and they establish also a deep learning model. And you see, when you look the result, it's not completely perfect, because when you see the failure rate of the AI recognition, it's more than 50% to correctly identify where are the nerves. So we are not exactly where we wish to be, but for the future, it's super promising. So at the end, we need, you understand clearly that we need to learn from our mistake of the past, when we were super happy, super satisfied to have very beautiful picture during surgery of pelvic, splanchnic nerve, etc. We need to respect them. We need to avoid systematic dissection where there is no indication, because we see more and more in the field of chronic pelvic pain, we see more and more some patients who had previously an extensive laparoscopic sciatic neurolysis, pudendal neurolysis. And when you look the histological results, and when you look the video of the surgery, there is no indication to do that. We have to continue to work. We don't have the time to discuss about that because it's very interesting about functional neuroanatomy, because we are very far to know everything about that. And if we have an indication to do something, we have to follow some surgical rules, that's clear. And we have to continue to think about the development of a suitable instrumentation and new method of nerve identification. So welcome in the field of neuropelviology. Thank you again for your attention, and bon appétit.
Thank you, Benoit. Alors, we gain half of the delay. So if you don't mind, we are going to move for the lunch, because I would like to be here at 2. Because I don't want to shorten the lab.
Mais il y a Katharina qui veut poser une question.
Hein?
Bon, elle la posera après. Il y a Katharina qui voulait poser une question.
Ah, but Katerina, you want to ask a question? Ask a question.
Yes, I want to ask a question practically. So said that we are able to see that there is a nerve involvement. I am able to see that there is a nerve involvement, say, on the sacral root. Should I call, in this case, should I stop my surgeons and call a pelvic surgeon? That means it is really a problem.
No, this is a job of the gynecological surgeon. If you ask, because in the most of cases, neurosurgeon is not able to do laparoscopy in the pelvis. It is not the role also of orthopedic surgeons, so that's why it should be the role of the gynecological surgeon, and that's why
but
it's so much.
Actually, it is not.
That's why we need to develop the education in this field, and we try to do that since a few years, but we are very far to have a good.
It will be, don't
But
worry.
it will be. This is the point, because a neurosurgeon probably will say to you, but it's not my work, my area of working.
But the most surgeons dissect the nerves, as you said, but there are no disease, and I'm a little bit skeptical that they are treating only the nerves where is the disease, and that they are able to have also the the technique to make a really this.
That's why we have to teach first the diagnostic approach and the theoretical knowledge, and after that, the surgical technique, even if
So
it's not well
actually we
studied.
go blind.
Yeah.
Okay, thank you, and bon appétit.
Bon appetito.
Did you enjoy this course? Why not join us in the beautiful city of Strasbourg in France to enjoy the full IRCAD experience on site? Learn from the very best experts in your surgical specialty and make the most of our exceptional facilities equipped with cutting-edge technology. Train and learn from the best, but also relax. Discover the magnificent 4-star Hotel Liara, as well as the Brasserie Liara, run by a Michelin-starred chef. It's the perfect place to talk to the experts and have a relaxing time. And don't worry, it's very easy to get to Strasbourg. You can get there from Paris, Basel, or Frankfurt, for example. Join us today. This is the best way to learn.